everybody to the Clinical Consultation Network. Of course, as I say every week, we do this every Tuesday at 12:30. And so I'm so glad that you could join us today. We have an outstanding guest. His name is Dr. Leslie Rubin. I've known him maybe getting close to 20 years since we met, and we're going to talk a lot about his career and some of the observations he's had over the course of his career. So I'm really anxious to get into that. We'll get to that in just a moment, Dr. Rubin. But I also want to mention today that about the NAD conference. So this is an exciting year in Tennessee because the NAD conference is coming to Tennessee. We are going to have right here in good old Nashville, Tennessee, the National Association for Dual Diagnosis has chosen this site, Lowe's Vanderbilt, downtown, for our conference on December 13th through the 15th. And there's going to be a great cast of presenters at this conference. I'm going to be presenting something. Matt Holder, whom I mentioned a moment ago, is going to be presenting. We're going to have a great lineup there. But also, we've got a little bit planned for the nightlife. I'm trying to get this all together, but I think what I'm going to do is do the Bruce Davis tour of Broadway in Nashville. And so we're going to go hit some of the hottest spots downtown. So if you're able to make that conference, you'll be able to participate, and I think you'll have a great time coming to the National Association for Dual Diagnosis Conference December 13th through 15th in Nashville, Tennessee, Lowe's Vanderbilt Hotel. All right, so coming up on CCN. Next week, we got it all together. We're getting it all together. We're going to do our greatest moments. We had a fail a few weeks ago, Dr. Rubin, and we weren't able to do our greatest moments. Of course, I've thought about this. It's some of our great moments is what I really should have said, because we've had a lot of great moments here on the CCN. But in a couple of weeks, or next week, we're going to talk about some of the greatest moments that we've had. And I think you'll like what we have prepared. We're going to rehearse this afternoon, so I think we'll be ready next week to present some of those greatest moments. On September 12th, we have Christy Kendall here. She is with Central Texas Behavioral Solutions. She is going to be here to talk about her practice on September 12th. On September 19th, we have Joey Ellis, who is going to talk to us about creating supportive schools for everyone. So that means including people with intellectual and developmental disabilities, which I think will be also a very interesting presentation on September 19th. So that's what we have upcoming on CCN. And with that, I'm so happy to welcome my guest today, Dr. Leslie Rubin. Dr. Rubin, welcome to the Clinical Consultation Network.
Thank you, Bruce. I'm honored to be in this network. It's an auspicious group. There's a lot of people here. Feels crowded.
Yeah, and I bet it's going to get even more crowded as we get going here. Dr. Rubin, you're the author or one of the editors of the book, Healthcare for People with Intellectual and Developmental Disabilities Across the Lifespan. You've had somewhat of a storied career in all of this. You've been through several different pediatric appointments and different sorts of things that you've done. Tell us a little bit about your career and how you got into all this work with people with intellectual and developmental disabilities.
You say this is only 1 hour?
I know, because if anybody read your resume here, I think they would know that it would take us actually all day to talk just about this one question. Give us a few of the highlights, though.
No, I'll just, just give you a little kind of brief synopsis, brief bio, as it were. I'm originally from South Africa, where I specialize in pediatrics. I came to the U.S. to Cleveland, Ohio, first at the Case Western Reserve, Rainbow Babies and Children's, where I did a fellowship in neonatology, this care of the high-risk newborn, which I was very interested in. But I realized it was too technical and too many night calls. So I decided I wasn't going to be doing night calls for the rest of my life. So let me change. And so I became more interested what happened to the infants after birth. And then I did another fellowship, which was called Care of the Handicapped Child. And that was really tremendous education. And from then on, I was in the whole field of developmental disabilities. I have to tell you also that in growing up, I had two cousins with significant intellectual and developmental disabilities, one of whom had cerebral palsy and one of whom had, I would say, mild to moderate intellectual disability. And they were my cousins, and we just kind
Yeah.
of hung out with them. And sadly, they both passed away a few years ago. It was a couple of years from each other, and they were 79 years old, almost 80, both of them. And it was amazing that they were then. And I even visited them very, very soon before they passed away. But I wonder if they inspired me, or the fact that my uncle and aunt were trying to get the best services for them in a place where there was very, very, very little. So they stayed at home, they lived at home and participated in all family events. Anyway, so after my Cleveland experience, I went to Boston Children's Hospital, where I also part of my work was to work at the Rentham Developmental Center. Rentham Developmental Center was one of those big institutions that was started at the turn of the century. This is a brief history of institutions for people with intellectual and developmental disabilities in the distant past. These schools, they were called schools, they were called. And initially, they had little kids come there to try to learn, but they knew very, 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 very little about education of kids who had any different kind of learning styles. And very soon, so many kids were referred there, and they had so little resources that these became sort of overcrowded, and the conditions became less and less favorable until they were quite terrible. And then until the 50s, 60s, 70s, with the civil rights movement came the rights for people with intellectual and developmental disabilities, and the expose of the atrocious conditions in these institutions that resulted in the emptying of these institutions and people going out into the community. It was called deinstitutionalization at the time. I always have to tell you that President Kennedy initiated a process to understand what what the issues were with people with IDD, and he created a panel, an interdisciplinary panel of experts to tell the government what to do. As a result of that, the government invested funds in opening centers around the country. There were two kinds of centers they opened. One was called a mental retardation research center, and the other one was just called a mental retardation center, which was clinical. So there was a research center, a clinical center. And when I went to Boston Children's Hospital, I worked in one of these centers. And this is where we learned about interdisciplinary approach to children and adults with intellectual and developmental disabilities. I was there for 14 years, and then I moved down to Atlanta, where I am now. And I started a number of programs here in Atlanta, and I continue to work in a number of programs, and have enjoyed working also in Tennessee, where Bruce and I met at a program called the Team Centers, which was in Chattanooga. A good, it was also interdisciplinary program for evaluating and managing kids with developmental disabilities. It was there, and Bruce, I'm preempting so many of your questions, but you can kind of ask.
Yeah, we'll get back to it.
Yeah,
That's all right.
and I just want to preempt it by saying that this team centers in Chattanooga, Tennessee, was run by June Phillips. June Phillips was an incredible manager, and she also was a visionary. And she hired Joan Beasley from Massachusetts, Boston, to come and help start a program for dealing with psychiatric disorders and crisis management for people with IDD. Um, that program became called the START, S-T-A-R-T, Center, or START Tennessee. And as a result of that, Joan Beasley became kind of entrepreneurial and created many such centers around the country. And now she has a national training center housed at the University of New Hampshire in Dartmouth, I think. Right, Dartmouth?
Yes, yes, that's
And they
correct.
have annual conferences attended by large numbers of people from around the country. And I had the good fortune to be there at the last meeting in Austin, Texas, right?
Correct, yes.
In May. So that's full cycle. And here I land up, and that's I land up here with you guys talking about my long and winding road of history.
Distinguished career, Dr.
Yeah, you
Rubin.
know what? I prefer Long and Winding Road. It's a song by the Beatles, if you remember.
Well, I know how you feel about that. Yeah, it has been a long and winding road. So, Dr. Rubin, why don't you just tell us, now, this is sort of a standard here on CCN, that we try to get an interesting fact about each person that comes on as our guest. I know, really, you have so many to choose from, but can you supply us with just one interesting fact about yourself that other people might not know?
Nah, man, that I speak to my therapist about.
Yeah, well, I always warn people, don't do too much information here. So, give us the interesting fact, but just enough to
All right, I will tell you. I will tell you. I'll just give you a little story because the story will introduce the fact, and the fact will perhaps open up discussion, or perhaps we'll just shelve it. But um, I've just given you like a trajectory of my story. But when I came to Atlanta, and I had one of my clinical interests was cerebral palsy. So I started a clinic for children with cerebral palsy in downtown Atlanta. Now, downtown Atlanta, Atlanta is a big city, is the capital of Georgia, and um, American cities. I started this in 1990s, and the cities were mainly populated by African American people who tended to be poor. And so this is a clinic in a hospital downtown opposite the Grady Memorial Hospital, the famous Grady Hospital. And we started the cerebral palsy clinic and had orthopedics and physical therapy and occupational therapy, speech therapy, audiology, nutrition, wheelchair people, orthotics people. It was an incredible team of people. Um, and after a couple of years, we'd collected about 250 patients, and I got some funding from a family who's had a child with disabilities, and they said, here's some funds, you can do with it what you like. So I decided to recruit some students to survey the population we had. We fortunately had collected the information on them in a statistical manner based on CDC diagnoses and criteria for cerebral palsy. And I was expecting to see a lot of kids with different kinds of medical problems. That was my interest, like how many medications they were on, or how many surgeries they had, or how many therapies they had, how many emergency room visits, hospitalizations, etc., etc. However, um, we did find all those facts that I was really looking for, and it predicted I would find. But one of the things that I didn't predict that I would find was that most of the children in that clinic were born prematurely, and they were born to young mothers who had used substances during pregnancy, like tobacco, alcohol, and in the 1990s, I think the drug of choice was cocaine at the time. And so many of the kids were born prematurely and often were affected by the drugs that their mother were taking. And also I found that 50% of them were living with single mothers, 20% with grandmothers, and 10% in foster care. So that just blew me away because I never realized up until that time, or I didn't realize up until that time, the powerful influence of poverty on the prevalence of developmental disabilities. And I then said, "Well, man, I've got to make a difference. This is really, um, there's something that's not right." And so I got some funding from the Governor's Council on Disabilities in Georgia to look into this and see what we could do. And the money was not very much, and because it wasn't very much, I couldn't really do a lot. But I decided that I would work with some students because students are eager, they're enthusiastic, and also they have new ideas and they're creative. And the bottom line is they don't cost as much as the professionals. So I was able to afford the project with the students, and I decided that I would recruit them to help break the cycle of children's health disparities. And what I mean by health disparities is that poor kids tend to have more developmental disabilities than kids who are more affluent or grow up in more affluent circumstances. And so perpetuates a cycle. So I called it a cycle of disabilities, cycle of health disparities. And I recruited students from Emory University Law School, Emory University School of Public Health, Morehouse School of Medicine, Georgia State School of Psychology, Georgia State School of Education. And we had this whole group of students, each of whom had unique projects. And then at the end of that project period, we had them present their findings at a conference. After that, I got more funding, and every year since then, we've had a program called Break the Cycle of Children's
Yeah.
Environmental Health Disparities. And we students from around the country. So far, we've had 180 students that every year we have 10, and they've developed projects, and we have them present their projects and write up their papers for publication. And we publish them in journals and books. And so that's one fact that is not doesn't come through when I'm talking in this forum. So if you ask me for one
Yeah.
unique fact.
Well, that was a great fact. So, in the title of the program was "Break the Cycle of Healthcare Disparities," and so this, I guess, I assume this was sort of your introduction to poverty. I don't know if we're saying that's a cause, but it's certainly part of a complex here where disabilities tend to come from.
Bruce, it's really very, very interesting. You see, it didn't strike me until I just saw that poverty has a powerful effect on children's health, and it affects more kids have asthma, more kids have lead poisoning, more kids are exposed to a variety of different environmental stresses. They're more likely to have learning disabilities. They're more likely to have hospitalizations, emergency room visits, and even cerebral palsy. So as I found out, so it sort of got me thinking, how can Leslie Rubin make a difference when the President Lyndon Johnson declared war on poverty and didn't quite succeed. And what am I going to do? So I decided, the bottom line is we can each do our own little thing. And if we can, enough of it and enough people do it, I think we can make a big difference. So that's my philosophy. And I just put the link to my program in the chat for anybody who might want to just look up the program. If you feel interested, just please check it out. And we're about to launch our 19th annual program, where we will be sending out invitations, and it'll be on our website to apply. So this is for students of all levels and all disciplines. It's not exclusive to health. We've had architecture students, we've had law students, we've had like city planning students. Yeah, it's just it's interdisciplinary and from all over
I
the
feel
country.
I feel quite sure many people from our audience are going to check that out. I think it's very important. So I would encourage everybody to check out that website that Dr. Rubin put in the chat. So our guest today is Dr. Leslie Rubin, and I want to encourage everybody to, if you have any questions, feel free to put them in the chat. We'll come to those in a little bit. Just things you might hear from Dr. Rubin that you want to get clarified, or something else you want to ask him about. Any particular type of medical condition that maybe someone you've worked with has experienced. Dr. Rubin is in a great position to be able to answer questions about that. And also, if you want to come off mute and ask a question, we'll happily facilitate that as well. Just let us know. All right. So you talked a little bit about the team centers where you and I met back in 2004, I think, somewhere in that vicinity at least. And you were doing some work there for the team centers. Tell us a little bit about the work that you were doing and how you got involved with that.
Well, the team centers, I think, had been going on for decades. An old program in Chattanooga, one of the unique programs dealing with children with developmental disabilities in Chattanooga. I think it was the only one for a long time. And they needed a pediatrician. So Alan Bullard, who was the director before June, found me and asked me if I could find somebody to work in Chattanooga. I couldn't find anybody. I said, I'll just come and help you out until we find someone. So that was sort of famous last words. I would find myself on a Monday morning leaving home at 6:30 a.m. to get to Chattanooga 8:30 a.m. and leaving Chattanooga 6:30 or even sometimes later to get home like 8:30 or even later. So it was a great day. And even though it was just once a week, I got to know a whole lot of wonderful people and got to work with the group. What we then found, I'll tell you what was so interesting, and the fact that I had been working with children with autism in the 1980s in Boston. And in fact, we started the first autism clinic at the Children's Hospital in Boston in the late 1980s. And then when I came to Atlanta in 1994, there was a program started by parents, but then parents gathered funds and they started a clinical program. It was called the Emory Autism Center, and I was working for a program called the Marcus Center, and then we started a clinic for children with cerebral palsy at the Marcus Center, and I started then I was going to Chattanooga, and nobody knew about autism or what autism was. And I realized that the only way you know about autism is to get familiar with it. It's not that it doesn't exist, that you might not be familiar with the wide variety of expressions of this very interesting and very confusing condition. And so when I was at team centers, we started to see lots of kids with autism, and we then decided we would start Chattanooga Autism Center. And I think that Chattanooga Autism Center is still going strong.
Oh, yeah.
And Dave Buck, who is the husband of the famous Karen Weigley of the START program, runs this program, and he sent me an email just like a couple of days ago to say that he was cleaning up around and he found a video of me giving a lecture to at their annual meeting and it was from about 2000. I can't remember, but it was a long time ago. It was almost 20 years ago. And I started watching it, and in it, I start to talk about the fact that the prevalence of autism is rising, and ask the question, why is that so? So then I stopped watching because I didn't want to watch myself from a long time ago. So anyway,
Well, yeah, we're still closely affiliated with Karen through the Start Center for Start Services, and then Dave has been our guest here on the Clinical Consultation Network before. So, we're still connected with them in a very strong way. So while they're, and by the way, you have been responsible for a lot of my education over the course of the years. One of the things I learned about was South African wines, and that South Africa is actually wine country. I've learned to appreciate a good Shiraz from you. But you have a history in South Africa, and tell us a little bit about the history of South Africa and good wine.
okay. Well, it is a very interesting question, interesting history. So I'll tell you, um, South Africa makes very good wines, and the wines in South Africa come from grapes that were brought by the French Huguenots. Um, I don't know if you know the history in Europe, but there was a lot of struggle initially, or not initially, but during the Middle Ages and later, the whole of Europe was controlled by the Catholic Church, except for Spain, which was under the control of the Muslims. But then the Catholic Church became very strong in Spain, and they kicked everybody out who wasn't Catholic. And be that as it may, but over the years, during the 17th, 18th centuries, a group of people were kind of rebelling against the control of the Catholic Church, and they created kind of breakaway churches and more reform type churches. And the reform churches sort of began to become quite numerous and powerful. And then the Catholic Church took over again, and these were wars. These were not just like kind of political issues. These were real wars. And so one group of Protestants, which is what the people were called, they protested against the control of the Pope and the Church, Catholic Church. But anyway, these group of Huguenots then needed to escape persecution, and so they moved to a number of different countries that were open, and some are in the US, perhaps on the West Coast, but many of them uh, took refuge in South Africa and brought their vines. So they brought their vines. The climate in the southwest part of South Africa is very much Mediterranean. And so they planted these vines, and they got good grapes, and they developed good wineries, and they do have very good wines. And one of my favorite is indeed, as Bruce said, the Shiraz, which is a very deep, rich red wine. Anyway, you're making me thirsty now, Bruce.
Well, so one of the things I learned, that I've been able to look quite sophisticated when I would have wine presented to me. I'd swirl it around in the glass, smell it, and say, well, I think it needs to rest for a little while. And that was one of the phrases that I learned from you. I'm not sure what all of it means, but I did learn to do that. It has carried me through many different wine tastings, so I appreciate that. We were talking just a minute ago about June Phillips and Joan Beasley, a couple of folks that we worked with over the years. Of course, both of those folks have had a huge impact on my career. I know they have, you've been partnering with them for a long time. Let's talk a little bit more about June and Joan and everything that they've accomplished through their work and that we've worked with them on.
Yeah, and as I said earlier, June Phillips was the director of the team centers in Chattanooga, and she really had a great vision of what could be done for children with developmental disabilities, um, and made the team centers really a very vibrant program. And it was she who hired Joan Beasley to come and bring her start centers to Chattanooga. And at that point, they got some funding from um, the state of Tennessee, right, Bruce? From, was
Yeah,
it the Division of Developmental Disabilities or something? Or
that's
mental
correct.
retardation?
And we were actually the first. She had started through the Sobner Center, started the START program in Massachusetts, and we were she commonly states we were the first satellite of the START centers. So we were the first ones where she developed this in another state, and so we were special in that way.
Yeah, and as you mentioned, the Sofner Center was named after a psychiatrist by the name of Sofner, who had started the center with Joni. And as you say, Bruce, this is what interested June Phillips. And this is why June Phillips was so amazing, because she looked beyond where she was. She looked outside. She looked for other ways in which she could do a better job. And I think that was her kind of strength and her talent. And what she brought was to look beyond where you are to other people who are doing good things, and if you can learn from them, bring it down to where you are, you can do a much better job for the people you're serving. And that's exactly her philosophy. That's exactly what she did. And she was fortunate to get Joan and Joan was very fortunate to have been found in that way, like a talent scout. So June was like a talent scout. She found Joan Beasley talent and gave her the opportunity to become one of the MVPs of the developmental disabilities world in starting the programs called START. And START was what, Bruce? It stood for
Uh,
strategic.
Systemic, therapeutic, assessment, resources, and treatment.
There we go.
So it's an acronym. Yeah.
And
I just drilled that into my head.
yeah. Yeah, it's great
Well,
to reminisce. And I'll just tell you, this is a philosophical comment that I kind of recycles in my head, much like your song about the cowboy. This philosophical thought that we often think that what we're doing is like, this is it. This is where it's been. It's like we walked into a place and this is how it always was. And this is how it always will be. But what we have to appreciate is the history of how it got to where it is. And through that, we can see how it can go to where it could be or should be.
and that is one of the hallmarks of the START program. We've been fortunate enough, we lost that program in 2009, but we've been fortunate enough here in Tennessee to get it back now. And we actually have teams across the state that are implementing the START program. And one of the hallmarks of the START program is continuous improvement. So we're never resting on where we are. We're actually trying to continue to make improvements to how we respond and how we help people who are in crisis. And so, you've been a big part of that over the years. You worked a lot, and you mentioned this earlier as well, with people with autism spectrum disorder. And I know that's been a large part of your career. What are some of the things that you would want our audience to know about working with people with autism spectrum disorder and how we approach them?
Well, yeah, that's a big question. First of all, it's so interesting that when I first started to see children on the autism spectrum in the early 1980s, when I started working in Boston at the Children's Hospital, and also at the Rentham State School at the time. And also that was the 1980s, and we're now in 2023. 2023 is 40 years from the time I started there, and it's now 80 years since the first description of children with autism. It was described by Leo Kanner, who was a child psychiatrist in an institution for kids with developmental disabilities in Baltimore. And he noticed there were a group of boys who had similar characteristics. They did not speak, they did not relate to people. They tended to be in their own world, which is where the word autism comes from, auto being self. So that's why he called it autism, in their own world, engaged in repetitive behaviors and often having major emotional outbursts. So that was his description, 1943. And now we're 80 years from there. Now, he originally called it infantile autism. That's what he called it. Why? Because it started in infancy and that's how the kids were since birth. The interesting thing is that those kids previously had been diagnosed with childhood psychosis and childhood schizophrenia. Those were the original diagnoses in the first half of the 20th century, before the 1940s, and Kanner coined the term infantile autism. And I tell you what I find so interesting is at the time, the reason the kids were labeled as having childhood psychosis or childhood schizophrenia is because they were in their own world and they were kind of not connected with reality. And that's what the clinical picture is of psychosis and schizophrenia in adults. So the language of adults, the clinical language, or the clinical language that's used to diagnose adults with mental health issues, was then kind of used to diagnose the kids. You may or may not be aware that today we're talking about adults who are on the autism spectrum. So now we're understanding more and more about adults now having the labels that were originally for kids. So we've really undergone a revolution. And Bruce, you know who really resonates with that kind of story is our colleague in North Carolina. Um, what's
Uh,
his name?
that we
Psychiatrist.
work with. Jared, are you talking about Jared
Jared,
Barnhill
Jared,
or
Jared
yeah?
Barnhill. Jared Barnhill really embraces that notion. But I did want to tell you about that because in the 1940s, when the first group of kids was described in a paper, people began to appreciate autism. And for a while, there was a diagnostic dilemma between what is autism and what is mental retardation. And it was a sort of big, major discussion, autism, mental retardation. Over the course of time, however, we began to appreciate kids who had less and less dramatic clinical pictures that was of the
Yeah.
original description, and they had milder and milder expressions of the condition until about the 60s, 70s or so, when the DSM, the Diagnostic Statistical Manual, added a new diagnosis, which was called pervasive developmental disorder of childhood, or
Right.
PDD. And so we then had two diagnoses. And when I was entered the clinical world, I had to make a distinction between what is autism and what is PDD. And I will tell you that was very, very tricky because it isn't a straight line. There's nothing demarcating autism and PDD at that time. And then in the late 1980s, the new diagnosis of Asperger's syndrome entered our vocabulary and our clinical thinking. And those were kids who were very bright and very articulate and academically did very well, but had the social issues. So then we had three diagnoses. We had autism, we had PDD, and we had Asperger's. By the way, do you know the term Asperger's is named after the child
Um,
psychiatrist Hans Asperger, who described a group of kids. He was teaching at a school, and this group of kids were very bright and very articulate, one of whom went on to get the Nobel Prize in astrophysics. And by the way, he used to call them his little professors. In the meantime, he wrote this paper on these little professors in 1944. Now, at the same time as Leo Kanner wrote the paper on autism in the US. But the reason we didn't find out about it is because Hans Asperger wrote it in German, because he was in
Right.
Austria. And we only came to learn about it when it was translated into English. And I think it was people in the UK who first connected with it and introduced the earliest concept of autism spectrum in looking at the range of
Right.
expression. Then only 10 years ago, that's 2013, that's 10 years ago, that the DSM-5 put together this whole picture and said, we're not going to be talking about autism, PDD, and Asperger's anymore. We're going to talk about the autism spectrum disorders. So that's how we came today to just say autism spectrum disorders, like we've known it forever and for our whole lives and for everybody's lives. But it's a relatively new concept.
Yeah. Yeah. Babs, we've got a question in the chat box. It's a rather long question, but maybe you can summarize it a little bit.
I was going to see if Diane is willing to hop on and ask it. I think she can be more succinct than I can. Diane, do you?
Okay.
There you go.
Yes, I'm here. Hello. I wanted to ask a question about energy needs and what your experience is with this, because I'm a registered dietitian nutritionist and I've worked in this field for about 7 years. And this is a very perplexing thing for me and has been from the beginning. There just doesn't seem to be any rhyme or reason to caloric needs for a lot of our individuals. I've worked with folks that are getting 3,000 calories a day and not gaining weight, and others who are getting 600 calories a day that look like they need to lose weight. And I work mostly with adults, not pediatrics. But I was just wondering what your experience is with this. We don't have indirect calorimetry. Obviously, none of the formulas that are out there for estimating energy needs really work for our population. So I was just wondering what kind of light you could shed in this area for me, and do you have any resources for me?
It's so interesting that you asked that question, because while I was in Massachusetts, I worked at a program that had children and adults with developmental disabilities. It's called the Berkshire Meadows. I don't know if you guys have heard it. Massachusetts is like north of the Mason-Dixon line, in case you didn't know. But that was a joke. But anyway, um, I was recently contacted by the nurse practitioner there, and she said to me, I'm working with this woman. She's in her 30s, and she is tremendously overweight, and we've cut back her calories to the bare minimum that I don't think anybody would really survive on, and she continues to be overweight. What should we do, or what's going on? So I consulted with my erudite um, endocrinologists and nutritionists, and to be honest with you, they couldn't come up with an explanation. They came up with some explanations of hormones and hormonal interaction, and cortisone, and all those hormones that address metabolism, but we really couldn't come up with an explanation. So here's my take on it, and it's my take on it. And you articulated very well actually in the chat. What we have to realize is when the standards are published, they standards for ordinary everyday people. In fact, some of the standards are calculated for adult males who weigh 70 kilograms or something like that. That was the old thing, So they don't even count women in it, or young people or old people. That was it. So now we're beginning to appreciate that every person is different and every group of people are different. So every group of people are different, but every person in that group are different. So whenever we talk about standards, we're actually talking about statistically derived um, criteria, or norms, if you want to call it that. And let me just give you an example. When you do some averaging and you do statistics, you usually add up a lot of numbers, and there's a formula where you calculate what the average is. So I'm going to give you the most basic example I can. If you have two numbers, you have and you add them up and you divide by 2, you will get the average, right? You can have a lot of people, but I'm just making it simple for purposes of communication. Number one, if you take 5 and 5 and you add injury, did they have some chromosome anomaly? Did they have some intrauterine insult? Did they have some birth trauma? Whatever it is, each one is like so completely different because of and part of the cause of their disabilities, and they have a different personality and they have a different physiology. So what you have to do is realize that everybody's unique and everybody's different. And although there's some standard metabolic principles and processes, there's standard nutritional guidelines, there's standards for energy usage, there's standards for factoring in energy usage and supply of calories. But in the end, you're dealing with individuals who have uniquely distinct metabolic processes, whether they subtly distinct or dramatically distinct, they're distinct. And that for each individual, you just have to recognize that unless there's some other metabolic or hormonal or neurological process going on, that you have to calculate their caloric needs for that person, exactly what that person needs. And you have to say, well, that's what you need.
Yeah, it's one of the things about statistical analyses, Dr. Rubin. Thank you for that question, Diane. That was great interchange there. I appreciate that. But one of the great important things to realize as you're reading research is that a lot of things are based on the average. A lot of analyses are based on the average person or the average person that's being evaluated in that study. And you have to be careful because there are individual differences that might not be reflected in that. So important. I was thinking back that I think you knew my old boss, Dr. Tom Cheatham. He had a formula that he used to try to understand different cases he was working with called Cheatham's checklist. It was a list of 10 things that he went through that were just important things to be thinking about when you're working with a person with intellectual and developmental disabilities. I remember the first thing on that list was blame the meds. That was one of his key phrases there. But also constipation was such a huge issue that he identified with people. I know that's been part of your practice as well. Just tell us a little bit about some of these other medical contributing conditions that may come up for people with ID that may explain why they're behaving in a certain way or why they're responding to others in a certain way.
Excellent question, Bruce. First of all, Tom Cheatham was like such an incredibly kind and gentle person, and yet had such sort of intellectual strength and clinical skills and even management skills. He really was quite a dear, and he just was a sweetest person. And as you say, blame the meds, what I want to say is that if all of us took the same medication, each one of us would have a completely different reaction. Some of us would say, wow, man, that's great. That's really helping me. My headache's totally gone. Or I can think now, I can think clearly. And other people say, oh man, gave me such a headache and a stomach ache and I couldn't sleep. And other person say, it made me cranky and irritable. So every medication acts differently. And again, as you say, Bruce, this we get like the average. And if they say this medication works for this condition, well, probably most of the time it works in maybe near sorry about that. Yes, so it might work some of the time, but it doesn't work all of the time. So no medications work for everybody the same way. Secondly, as I was trying to say, some medications may have adverse effects, headaches,
Right.
stomach aches, toothache, not toothache, that's something else. Whatever, can make you irritable. I will tell you from my own experience, antihistamines, just like when I've had allergies in the past, I can't take antihistamine because I feel weird with antihistamine.
Mm.
So if you say, Leslie Rubin, you feels weird, I say, I mean, I can't think straight. It makes me weird. Now, you take a person who cannot speak and who's feeling a headache or weird, that person's going to behave in a strange way because he can't tell you. You know, I can say, hey man, I'm feeling strange today, or I've got a headache today. It's terrible. I can't think straight. You know, that kind of thing. But a person with some intellectual disability is not able to tell you. So he's going to like somehow express pain or discomfort or mental confusion, whatever it is, in a way that's not usual. So I want to just, this was probably another one of Tom Cheatham's list, is that whenever somebody behaves in a certain way, it's not a behavior, it's a sign or an indication that there's something bothering that person, and we have to try and find out what is bothering that person and how can we get rid of it. And Bruce's comment that Tom Cheatham said, blame the meds. And that's because you have to think about medications as causing just about any symptom in
Yeah.
anybody, and particularly people who can't speak. You've got 3 more minutes, Bruce. What
Well,
would you
yeah.
like me to say in
Well,
3 minutes?
I wish we didn't have to stop here because this has been a fascinating interview with Dr. Leslie Rubin, one of my heroes from the past and for the present as well. I so appreciate you being our guest today, Dr. Rubin. This has been very good discussion, and I think it has educated our entire audience. So I appreciate you coming on and being our guest today.
It was my pleasure, and thank you, Diane, for your excellent question. And what I like about your question is that you had some idea of what should happen, and when you encountered the reality of life and of varying physiology, you said, "Wait a minute, this doesn't make sense. It's not really working out." And the very fact that you asked the question is great. And I think if we can all ask questions when things don't seem to be going the way it should, that's the way we all learn and teach each other. So I thank you for what you
Thank you.
asked us and all those things. Okay.
Yeah, I do thank Diane for demonstrating how you can ask a question and get it answered here. You know, that's a very good process, I think, and what we're really what we're here for with the Clinical Consultation Network. So thankful for that. So thankful for all of our audience. Of course, join us every Tuesday at 12:30, where we'll have another fascinating guest each week. So thank you so much again, Dr. Rubin. Thank you, Babs Tierno, my producer. And we will see you again next week, everybody. Thank you.
Thank you, Bruce. Thank you, Babs. Bye, everybody.